We are thrilled to be back in South Florida with this amazing MCI team. Dr. Reyes, I think we've been doing these living rooms down here now regionally for almost a decade. So thank you so much to all of you for being here tonight. And tonight, we're going to be talking about multidisciplinary care, this multidisciplinary team here, why it's important when diagnosed with lung cancer that you have multiple disciplines looking at you and taking after your care. So we're thrilled to have you. This programming is for you. And now I am going to turn it over to Dr. Reyes and this entire team, who again should be wearing capes based on some of the things that you guys have shared. And I'm really excited to hear you guys talk about who you are and what you do.
Daniel, for the introduction. For the ones that are online that don't know us, we are Memorial Cancer Institute. We are part of the Memorial Healthcare System here in Broward County in Florida. We are the third largest public healthcare system in the country because we have 6 hospitals here. And then our mandate, because we are a state public institution, is to take care of South Broward citizens. We cover around 600,000 citizens that we need to protect. It's a pleasure to collaborate with the GoTo Foundation. We are collaborating for more than 10 years. I had the honor to meet Daniel's mom, Mrs. Bonia Dario. She's probably watching us, and her passion to fight this disease is unique, and I thought I was very passionate until I met her, and then now we have a lot of collaborations like this, you know, like our 5K that we do and other things. So tonight in these programs, we like to share and talk about what is happening in lung cancer that is important for our patients. That's why we invite you tonight. And from the memorial side, I think it's easy because I'm the director of the cancer center. I get all the accolades. But honestly, our lung cancer team is more than 40 people. You know, we meet every Monday for our tumor board. Dr. Block here is in charge of our tumor board. We are 40 people fighting for you. Many specialties. We only have here 8 representing, but we have many other specialists like interventional radiologists. We have our administrators in charge of the approvals and authorizations. We have a lot of people that are not here, but this is an effort of our healthcare system for you. We are public, we are for the people, and that's what we do. Now we want to share briefly, because we want to also talk to you about what we do, so that you can understand what is important. The topic tonight is the multidisciplinary approach. We are not going to talk specifically about any new drug. What we want is to understand that how this multidisciplinary approach that we invest in the healthcare system makes a difference in the lives of many of you, as you know. To give you an example, there was a time that when the patient goes to the primary care and they found a mass in the chest, it takes 90 days to see the medical oncologist, 90 days. So this cannot happen anymore. You know, you don't want to. Dr. Block probably can tell you about the statistics about delaying surgeries, how bad it is. That's why it's very important this, and we want to briefly share with you. So I want to ask each of us to introduce ourselves and maybe say what we do and how we work in lung cancer. So we're going to start with Michaela, that is our navigator, because most of you, when you call, is the first person that you meet.
Good evening, everyone. I feel honored and privileged to be here with all of you. Most of the time we connect over the phone, so it's really a joy to see you in person, meet you in person. My name is Michaela. I'm a patient and a family navigator at Memorial Cancer Institute. My role starts, usually we are the first contact with the patient, so basically when you schedule an appointment, we reach out to you. We discuss and review your medical history over the phone, make sure you are prepared for the appointments, initial appointment, and obviously we follow up with you after the appointment to make sure that you stay compliant with the plan of care that is recommended by the oncologist. Most of the time, patients call us for different things. After the first initial visits, they call us to make sure they get support to make appointments for biopsies, or they don't understand, for instance, they need more information about what's the PET scan, how do we prepare for that, or just to change different appointments and so. In addition to that, during our phone calls, we assess to make sure you know about our supportive services that we have available. nutritionists, social workers. We have psychologists available for you. We offer also emotional support throughout our contacts and discussions, as well as we keep and cement your communication with the medical oncology team. And we place referrals to make sure you connect as soon as possible with the surgical team or medical or radiation oncology team. So welcome to Memorial, and you have a navigator here if you need help.
Hello, everyone. Nice to be here. Nice seeing some of the patients I've treated here, and I want to just say congratulate all the lung cancer survivors. I think as a clinician and oncologist, it's always nice to see. This is the reason why I think a lot of us became clinicians and oncologists, is really to see our patients more in a natural setting and not necessarily in sometimes the artificial setting of the clinic. But I'm Dr. Ignacio Castellan. I'm the Chief of Radiation Oncology at the Memorial Cancer Institute. In the Radiation Oncology Department, we're 6 radiation oncologists, and we work in a multidisciplinary fashion with our colleagues, as Dr. Raya was saying, in medical oncology, thoracic surgery, but also with all of our support services. And our role in radiation oncology, we view it as working together with our colleagues really to try to come up with the best treatment plan for our patients and really tailor each patient's treatment based upon their cancer type, their stage. And as a radiation oncologist, really my role is really to try to give recommendations as to when we think radiation is appropriate, and not just when, but also what type of radiation. So in relation to lung cancer, many times we'll introduce treatments such as stereotactic body radiotherapy for patients with early stage disease that may not be a candidate for surgery. So many times we have these discussions with Dr. Reyes, Dr. Block, and we really try to assess as to what's really going to be the best treatment option for the patient. Sometimes we offer radiation as an adjunctive treatment, maybe after surgery, if there are indications for radiation. Sometimes we may do it in combination with chemotherapy and do a more protracted course of treatment. And even in more advanced stage disease or metastatic disease, many times we'll make recommendations as to offering radiation to maybe treat isolated tumors or isolated metastases to really help with quality of life and more control of the disease. I can't stress the importance of really having a specialist of each individual field really collaborating together in a real-time fashion, really so as to really be able to offer the best treatment to our patients. And also being up to date really with the latest advances in treatment. I could tell you that in the 14 years I've been in Memorial, things are always continuously changing in oncology, especially in lung cancer. And as things are evolving, I could tell you the general evolution of radiation has really been to be more selective in the use of radiation, being more targeted with radiation so as to try to limit side effects for our patients. A lot of that is really Dr. Reyes and Dr. Domingo can talk a little bit more about the latest advances in immunotherapy and targeted therapy in terms of treatments that target a specific mutation. We like to think in radiation that we do targeted therapy and that we really focus radiation to where we see masses or nodules in the body. So I think that's the role that I play along with my colleagues in radiation oncology and in the thoracic oncology tumor board.
Hi, I'm Dr. Helenis Domingo. I'm one of the medical oncologists at Memorial. Along with Dr. Reyes, we specialize in lung cancer. It is a very exciting time for lung cancer. I remember when I was a fellow where lung cancer survival was at a much lower rate. But now we have many options to treat lung cancer, including chemotherapy, which has been established for many years, but now we have, in addition to that, immunotherapy and targeted therapy that we can offer to patients, and we really try to tailor the treatment to the patient's specific tumor type. And for this, it's very important that we order molecular testing for patients, and it's something that, at least at Memorial, we've been doing for all of our patients. And it's important to do it from both blood and tissue, and that way we can identify the specific molecular composition of the tumor and better decide what treatment is going to benefit the patient. And the outcomes that we're seeing, it's very rewarding to see how many patients, even with stage 4 disease, are alive many, many years after their diagnosis. So it is a very exciting time for us in lung cancer, and I am very happy to be here with you today and to be part of this team. Thank you.
Okay, so I am Luis Rice. I'm also a medical oncologist. We work with Dr. Domingo, and we work also with Dr. Hunis. We are three medical oncologists that do lung cancer. To add what Dr. Domingo said, nowadays for us, the most important thing is to classify the lung cancer as soon as it's diagnosed. And for that, we really need the molecular testing. At Memorial, for many, many years, we already do liquid biopsies. Yeah, in many centers, they do the tissue biopsy, and only if it's negative, then do the liquid biopsy, but that takes and delays the treatment of the patient weeks. In Memorial, for the last 7 years, every patient gets a blood and the tissue molecular testing from the beginning, and all academic centers in the United States do that, and I think this is the right thing. We have a lot of stories that, thanks to that, in 8 days, 9 days, we can discover if you're a candidate for oral therapy, for a pill, and that can make a big difference in your treatment. Anyway, so we will be happy to answer questions about these things. That's why I'm not going to spend more time, and we'll wait for your input and your comments.
My name is Mark Block, and I am the head of the thoracic surgery program at Memorial. I have a couple of partners, Dr. Tarazi and Dr. El-Zaidi, and some of you may know Dr. Razi, who was with us briefly a few years ago. He's going to be coming back, so there will be 4 of us in the fall. And I've been with Memorial now for 20 years, and it's really been a pleasure, an educational experience to be with this group, and it makes you want to perform for your patients and do the very best you possibly can, not just because your patients care, but because all of your colleagues who are really superb are expecting you to be equally good. Most of you probably don't know that surgery for lung cancer has been around for probably 80 years. The very first lung cancer operation was done in St. Louis by a surgeon by the name of Evarts Graham. He did a pneumonectomy on a gynecologist from Baltimore for lung cancer. That was in the 1940s. And the gynecologist actually survived Dr. Graham. He survived his lung cancer and outlived his surgeon. So surgery has been the cornerstone. Surgery has been the cornerstone of lung cancer treatment ever since. And one would think that with all of these advancements now in non-surgical therapies, radiation therapy, targeted therapy, so forth, we would be phasing out the need for surgery. But what we're seeing as part of this multidisciplinary group is that it's actually becoming more important. Not only are we now operating on patients with early stage cancer who are now given treatments, and previously there was no treatment for somebody with early stage cancer who had surgery. You just kind of rolled the dice and did what you did. Now, Dr. Reyes and his colleagues have treatments that have impact and efficacy in these patients. So not only are early stage patients now working with the oncologists, but we are also seeing patients who were previously unresectable, responding to a lot of these great new drugs, and now we're considering surgery for patients who maybe never would have been considered candidates for surgery. So all the advancements on the molecular and targeted and therapeutic level and with radiation therapy are actually making surgery a more important role in the multidisciplinary treatment of lung cancer. And it's really my privilege and pleasure to help guide the surgical component. We are fortunate that Memorial provides us with all of the latest technology. We have multiple surgical robots. You've probably heard about those. We have several of them at our campus at East and several at our campus at West. We have our latest technology in invasive diagnostics, bronchoscopy, and biopsy material. So we're fortunate to have all the technology. But it's also really important to make sure that we focus on what's best for our patient and maintain the fundamentals of quality patient care and not let the technology drive the care. The patient drives the care, and the technology is a tool to help us do it better. So it's really a pleasure to be a part of this group. I'm a pleasure to participate in this evening like I've done before. It's a wonderful event, and congratulations to GoTo Foundation for really making such a great impact, and thank you for including me.
My name is Brian Gotkin. I am the medical director of the adult pulmonology group for Memorial Physicians Group. I have 3 other partners right now, Dr. Gittler, Dr. Furman, and Dr. Betancourt. We've been a part of the Memorial system for a long time. I've been there for 23 years. My partner's been there for longer than I have. We're typically the first stop in your journey along your lung cancer route. We will see the patients whether they come from an incidental finding of a lung nodule on a CT calcium score or on a CAT scan of the abdomen or through lung screening. Our goal is to find cancers at an earlier stage now. Typically, we would find them later on because people wouldn't present until they were symptomatic, and at that point, it was already stage 4. And I've heard a lot of patients in this room who already have stage 4 cancer. So I'm very involved in trying to find these lung cancers at an early stage. We have an incidental lung nodule program for those who have the CT calcium, but we also have a screening program for people who are at high risk for developing lung cancer, starting at the age of 50 and going up to the age of 80. And these are high-risk patients, people who are smokers, who either quit smoking within the past 15 years or who actively smoke. Not everybody who gets lung cancer was a smoker, but it definitely puts you at a higher risk. So we are very involved in finding the lung cancer, diagnosing the lung cancer, staging the lung cancer, and following the patient through their journey. So oftentimes, like you had an incidental finding. You probably had a pulmonologist involved in your care, Dr. Gittler, my partner, who helped in the diagnosis of it. So we work very closely with Dr. Block, Dr. Reyes, in helping diagnose the lung cancer, whether it's through a CT-guided biopsy or bronchoscopy or endobronchial ultrasound biopsy. And then we work together, like you were saying, every Monday we have our tumor board, patients are presented, and we come up with the best course of action for that patient. So we typically get involved in doing pulmonary function tests and assessing someone's ability to undergo surgical resection. We also help in maximizing their ability to undergo surgery. So most people, like I said, who have lung cancer are smokers or were former smokers and may have some underlying emphysema, COPD. So we help in treating those patients, getting them ready for surgery. We also follow them through their course. So sometimes there can be complications related to some of the immunotherapy or related to some of the radiation. And we're there all along the way working with medical oncologists, radiation oncologists, and thoracic surgeons. And we're sort of like the constant force through the course. And I'm glad to be a part of this group. And we're here for you guys, whatever you need. Thank you.
Good evening. My name is Marisol, and I'm a pharmacy tech. I've been a medication access specialist in oncology since 2019. My role is to assist patients that are experiencing medication access barriers to help obtain and maintain their prescribed therapies. My goal is to decrease the financial burden that uninsured and underinsured patients experience due to high-cost specialty medications. It feels very rewarding to be able to help our patients afford their therapies. I understand the importance of being able to start treatment and work closely with you and your direct healthcare provider in facilitating access to your medications.
Thank you, Marisol. She's very humble because she's the most important member of the team. You know, no, I can prescribe you the best pill for lung cancer, and you will never get it if it's not because of her. You know that.
I can go more into depth. So, when I get referrals for assistance, I evaluate each case and identify the best program options to meet your needs. Not a lot of patients are aware that many drug companies offer assistance programs that provide free or reduced cost medications. Some of them are income-based. However, each foundation is able to set their own guidelines, so they're not just for low-income families, which is great because it allows a much greater population an opportunity to enroll. So the medication access specialists will complete the applications, have them submitted, do follow-ups directly with the programs to ensure that there's no potential delays in treatment. We do assist and provide support throughout the entire enrollment process, which also alleviates, some of the stress and burden that our patients may already have.
It's such an important role. I know at the foundation we have a helpline, and 60% of our callers are looking for some sort of assistance in paying for the care that's being prescribed to them. And it's a cancer diagnosis, let alone a lung cancer diagnosis, is in and of itself a heavy burden. And then to be told this is the best treatment option for you, but sorry, you either can't afford it or get access to it for whatever reason is such a huge role. So, and the fact that Memorial even has this as part of their multidisciplinary team is such a testament to the work and the care that you give to the people diagnosed in this community.
Yeah. So we just want patients to know that we're here to provide support and navigate the medication access journey.
Thank you, Marisol. No, this is very important because I think I told you at the beginning of the conversation, we are the public healthcare system. So if you live in our territory and you are uninsured or you have a bad insurance or whatever, we know that we need to help. And in that regard, I want to give thanks. We have a lot of people from the industry tonight here also. We want to give thanks because the industry has been very supportive when we have patients that don't have insurance to provide replace the drug that we use, either IV or pills. So that's why we are very, very grateful because this is the only country in the world, because our society is worldwide, ISLC, we know that. This is the only country in the world that we will get free drug if you don't have insurance. Okay? So it still works here, so we are very proud to be in this country. But the problem is the other ones, the middle class, we. Okay, so I have a challenge to you. If I prescribe you today a $20,000 pill, what is your copayment? Who can tell me what is your copayment? I don't know. I don't know what's my copayment. If somebody prescribed me a $20,000 pill, I don't have a clue what's my copayment. I have to call Marisol. I say, and the problem is then most of us discover, the insurance says, no problem. You are covered. Your copayment is $500 a month, $1,000 a month, $2,000 a month. You say, what good coverage is if I have to pay $2,000 a month? That is why the middle class, we have a major issue that we need to be calling, and we need reimbursement specialists to help us navigate. So I'm very proud to say, to make this story short, in 13 years I work at Memorial, I had never have prescribed a pill and the patient never got it. One way or the other, the patient gets the pill. Yeah. So we want to hear from the patients. If you want to make any comments, or...
Hi, Dr. Reyes. I wanted to ask a question because I was fortunate enough you knew about the biomarkers, and I qualified for the biomarkers, so I've just been on the target therapy, didn't have to do radiation, and I'm stage 4, so I didn't have to do radiation or chemo. And so after the 6 months of taking this pill, I had no side effects, not one side effect. Dr. Reyes didn't believe I was really taking the pill every day. Until I got my PET scan back, and so, as I said, of last week, my tumor was totally dead. So does that mean I'm cancer-free, or do I have to wait for the 2 years with the pill? What does that mean exactly?
There is no evidence of cancer, but we know that to be cured, we need to wait 5 years at least, normally, because lung cancer grows fast. If it's hiding there, it will grow back at some point, but you don't have to wait 20 years. We most of us put a 5-year rule. So you are in remission, but hopefully, you'll reach your 5 years. We have people here that have reached 5 years. We have in the practice very blessed. We have people that have reached 20 years. So you never lose hope because you never know who is going to be successful. The best thing is you always have to fight,
So I have an add-on question to that. Once people get to those 5 years, and I have patients that I talk to who have been on their targeted therapy with no evidence of disease for 10 years, and they're terrified to come off drug.
Yeah, that's the issue. We're scared too because when we find disease recurrence on a scan, that means there's cells there that to form a tumor that is at least half a centimeter in size that we're able to detect it in a scan. And by that time, that means there's many, many cancer cells that are growing. So everyone puts the patient on the pill, and then when can we take it off? It's a little scary that we take patients off these pills, and then the cancer comes back, and it comes back with a vengeance, and then can we get it back into remission? That's questionable. So a lot of us tend to keep patients on the pill as long as they're tolerating the treatment with no side effects, and the cancer seems to be doing well, and we should keep an eye and keep watching you.
So we can stay on that pill forever, as long as it's working, right?
Most of these pills are new. Remember, we didn't use pills until 10 years ago, probably, and so that's why we need more evidence, more data. So one day we'll tell you, like they do in breast cancer, there are pills in breast cancer you take for 3 years, they got pills for 5 years, and there are others that, I think I'm taking for 10 years. But, that's why we need more time. We need more time. But in the meantime, as Dr. Domingo said, the pills are non-toxic. If you don't get sick, actually, I have survivors from 8 or 9 years. I tell, hey, if you want, don't take the pill and let's see what happens. And they say, no, I'd rather take the pill than don't take the pill, So, because they are not very toxic, so.
To me, it seems like a silly question, but I've been wanting to know, how many non-small cell lung cancers are there? Like, I was diagnosed with adenocarcinoma, and I'm just wondering how many other non-small cell cancers are there? I guess, how common is my lung cancer, adenocarcinoma? Is that more of the more common lung cancers?
So every year there are about 170 or 180,000 people diagnosed with lung cancer. About 80% of them are non-small cell lung cancers. So 20% are small cell. The non-small cell category is made up primarily of two different types. Adenocarcinoma is the most common. Squamous cell carcinoma is the second most common. And then there are a handful of others that are, 5-10% of the rest. So adenocarcinoma is, I think, about 60 to 70% of non-small cell lung cancers.
Okay, thank you.
I think it's a really interesting question, too, because even in the 20 years that I've been living in this lung cancer space, things have changed drastically, right? Which is one of the reasons I think a multidisciplinary team is such an important part of a person's care. But even when you look at adenocarcinoma, and then you look at biomarkers that could potentially be associated with that, we break it down even further. And in the adeno space, I've been known to refer to it, particularly in those that do have biomarkers, as a series of more rare types of lung cancer. So you're dealing with a rare cancer versus lung cancer as a whole, which is the most common. I mean, how do you explain that, I guess, to your patients, right? Because EGFR, for example, is what, 15%?
Yeah, we have, in the adenocarcinomas, we have a lot of biomarkers. We have more than 15 oral drugs approved for adenocarcinomas. But in squamous cell carcinomas, we do have biomarkers. The problem is that we don't have the drugs yet. So we know the targets, and we are working very hard to develop drugs, but we have not been very successful. The same in that small group of small cell lung cancer. Small cell lung cancer is not like there is no marker. There is targets, but there are targets, but we haven't been successful developing the oral therapy against those markers. At the end, the future of oncology is going to be like that. So in lung cancer, we are the ones that do more molecular testing, but sooner or later, in the other cancers, they have to do the same, because as we know, the tumors are not, doesn't matter even where the tumor is located. No? For example, in Memorial, we participate in the approval of a drug called larotrectinib that was approved in 2018. The drug was approved with only 60 patients in the world, because unfortunately, it's only 1% of the lung cancers, But it was a very compelling, because these 60 patients have failed everything, and pretty much all of them responded. But the interesting thing is, there were not 60 patients with lung cancer. There were 60 patients that have 15 different tumors. So this drug works now, today, works for more than 20 tumors. And 3 or 4 of these tumors were tumors for kids. So that's why we're moving from, we're going to treat the cancer based what is located to what is the molecular aberration that the cancer has. Because this pill works in a target called NTRK. NTRK is in lung, is in breast, is in sarcoma, is in adults. There are kids with a weird tumor called nephroblastoma. As long as the genetic aberration is responsible of the cancer, the pill can kill it. So that's why we're switching from, I'm an expert. There is not going to be lung cancer expert in 20 years here. Maybe we'll be an expert in some molecular aberration.
Right.
Because that is what matters nowadays. That's what Domingo was talking about. The molecular testing is extremely important. And you, as patients and patient advocates and family, when you go to the doctor, you have to say, doctor, are you going to do my molecular testing? They say, oh, yeah, we did it, and it was negative in the tissue. No, I want now to get it done in the blood, because that can be a lifesaver, or at least give me a chance to fight, or to prolong my survival, because all the science is based on that, looking for targets for lung cancer so we can have less toxic therapies that are more efficient.
Is that the testing you do prior to treating the
Yeah.
patient? So if I was with you for the last 4 years, you did that for me?
Yeah, as I was
Okay.
saying, everybody gets done in blood
Right.
and in tissue, so we have a double opportunity to find something that can be helpful for you.
Gotcha.
Dr. Reyes, could you explain a little bit what you're saying about a tissue biopsy versus a liquid biopsy, and maybe explain the heterogeneity of and why both?
Yeah, what happened is we discovered these genetic aberrations, these gene alterations in the tissue. So that's why for the last 7, 8 years worldwide, you have a new patient diagnosed with lung cancer, we start to look what is in the tissue, the genetic aberration. The problem is because we had to ship these tissue samples to some laboratories. Sometimes you call pathology and say, please ship the sample of Mr. Rice, and the pathology technician is busy. Oh, I'll do tomorrow. I'll do next week. Today is Friday. I'll do Monday. So the moment that you ship the sample and the sample arrives, takes 2 or 3 weeks to be processed. And all of this time, you already visit us. We already told you you have lung cancer, metastatic. You need therapy, and we cannot tell you what therapy is. And you need to wait 1, 2, 3, 4 weeks. So that was very frustrating for the patient. So that's why we were lucky that they developed what we call liquid biopsies. So what we do is in the blood, we take a blood sample, we isolate the tumor DNA, and we run the molecular testing there. It only takes 8 days. So in 8 days, we can tell everybody what is the treatment for you. Okay, but I mentioned it before, this is not done in all United States yet. Everybody's still doing the tissue, and sometimes do the blood only 3 weeks later when the report said, oh, there is not enough tissue. And now they send the blood, and the patient keeps waiting for the tissue, now waiting for, it's a lot of waiting, and nobody wants to be waiting when they have a bad diagnosis.
So, but Louis, you can't make a diagnosis of lung cancer based upon a liquid biopsy. You still need tissue for the diagnosis, correct?
Yeah, that's the most amazing thing, So we diagnose lung cancer or any cancer in the tissue. But, we have limitations. This is a very important question, Dr. Gonzalez. There are technologies and companies that are trying to diagnose cancer in the blood. So that is our ultimate goal for all of us. We want you to go to primary care every year, check your cholesterol, whatever, and check a blood test that can tell, hey, you have lung cancer, you have this, because it takes 800 mammograms to find one breast cancer. Okay, and it takes 250 CAT scans to find one lung cancer. So the other ones are a waste of time and you're exposing people. That's why this is a very important question. You're going to hear in the news, there are several companies advertising, hey, we are very close, we are going to make it. We don't recommend, as a cancer society, yet any of these tests. But you're going to hear there are companies that are trying to isolate the cancer in the blood, and some of them are more successful than others. But I hope it's the future. Yeah? For us, my dream is that you go to primary care, they draw the blood, oh, it seems that you have breast cancer, that's the day you go for your mammogram. The rest of the time, you don't need mammogram. And then we do the same. And the advantage of that is today, if you think about, we only screen for 4 cancers or 5 cancers. We will draw the blood and we'll screen you for 50 cancers. We'll screen you for pancreas cancer, liver cancer, a lot of cancers that we'll never found unless we screen you. But there is no screening for that.
That seems so far away.
It's much closer.
It just
No, the reason why we are warning you is because there are companies that today, if you pay $800, they will do for you. What happened is it's not very accurate. So that's why we warn you that we're very close, but it's not standard of care yet. We want them success, in other words.
Like if you get a PET scan now and it comes up clear, is it still very important to go get that mammogram and that colonoscopy and all of those type of tests since the PET scan came up clear?
Yeah, it's still very important because, for instance, like in the breast cancer world, there could be some breast tumors that maybe are not very active on the PET scan, and they could be missed on the PET scan. So many times with breast screening, many times they'll do a mammogram with an ultrasound, just because there could be some tumors that, even though it's negative on PET, even the radiologist will mention, this tumor is not very metabolically active on the PET scan, you may want to consider getting another imaging test to better detect or screen. So specific to like breast cancer, there are many instances in which we can see low-grade breast cancers, sometimes like lobular cancers that don't really show up well on PET scan. And it's still worthwhile to get mammogram and ultrasound. Even for colon cancer, the idea behind a colon cancer is really to detect a small polyp when it's really not even detectable with imaging studies. And many times you can have a small polyp that won't get picked up on an MRI or a CAT scan, but on the colonoscopy, the gastroenterologist can see the polyp and they can remove it, and then they can test it. So those screening tests are still going to be very important. Just because you have a negative PET scan doesn't necessarily mean that a person is completely cancer-free. I mean, it's news nobody wants to hear, but sometimes those screening tests are still going to be important for those patients. You know, very commonly what we see in the clinic, it could be maybe a lung cancer patient getting a PET scan, and there could be an incidental finding either in the breast or some other organ. Exactly. And the radiologist may call to the clinician to call it to their attention that the patient should maybe be sent for additional testing or imaging specific to that organ. Exactly. So a negative PET scan doesn't necessarily mean that one is absolutely cancer-free. It's a good bit of news. But a PET scan can have incidental findings where maybe additional testing may be required to find it.
So I'd like to add just a little bit about PET scan, because I have this conversation with my patients all the time. I think there's a general misconception that a PET scan is a cancer test, and it's really not. Okay, a PET scan is a test that demonstrates increased metabolic activity. Right, so metabolic activity is how our body uses energy, and the more energy that a tissue is using, the brighter it will show up on the scan. So anything that's got increased activity is going to light up in proportion to the extent of activity. So for example, the heart, which is constantly beating, has a high metabolic rate, and it shows it very hot on the PET scan. So cancers will light up on PET scan depending upon how quickly they are growing. Rapidly growing cancers will be very bright. Some cancers that are growing very slowly will have no activity at all. And then other things that we see in the lung or other parts of the body can have activity but not be cancer. The most common is a source of infection, a site of infection. You can imagine there's a lot of activity at that site of infection. Those areas can be very bright on the PET scan, so they can be misleading. So a PET scan is not a cancer test. It's very helpful. The way I discuss it with patients is that if we know you have a cancer, it's helpful to get a PET scan to see whether it has spread anywhere. It doesn't really tell us very much about the cancer itself, but it tells us whether it's in any other places. That being said, it's not a perfectly sensitive test. Small tumors are too small to be seen on the PET scan. So it's very helpful. I think it's most helpful in what we call staging. It's not great at diagnosis.
If the technology is so efficient, if the medication is so advanced, what about the secondary effects of those medications? Because there are some patients that are struggling with the secondary effects of the drugs that seem to be so sophisticated, but then they're still having now issues with the side effects.
That's one of the most important topics that we were just discussing now. And that's why we're trying to move away from the more toxic therapies, such as the chemotherapy. But even in that terrain, we've made a lot of advancements. Like I remember before when we give chemotherapy to patients that would be vomiting and very, very, very sick, hospitalized. Now we're at a point where we have come up with a lot of medications to prevent that from happening. So typically patients that go on chemotherapy, they'll receive antiemetic drugs to try to prevent the nausea from coming on even before it starts. And then we have newer medications that we can send home with the patient that they can use in case nausea develops at home. Similarly, we have growth factor support, which are injections that we can give patients to try to boost up their immune system after chemotherapy is given to try to prevent that infection from coming in. But the most important is that we're trying to move away from chemotherapy and hopefully identify a target in every patient that we can treat with targeted therapy and move away from chemotherapy. And that's what Dr. Rice is describing, that hopefully in the future, we're able to discover the mechanism of pathogenesis in every tumor and target that specifically and try to move away from chemotherapy, which is a more broad approach to cancer treatment.
Side effect management we get calls about that a lot too, right? And a lot of times actually people living with lung cancer are afraid to talk to their healthcare provider for fear of coming off drug and not really having another best first option. Palliative care is something that we're really big on at GoTo, and having conversations with our patients that come in and their loved ones about talking to their healthcare providers about this supportive care. I think there's still some confusion out in the lay world about palliative care versus hospice care. So can you talk a little bit about that?
Yeah, we do have, as part of a multidisciplinary team, palliative care and hospice care, well, hospice referrals as options. Palliative care referring to treatment of symptoms that can come on as a result of the cancer or the therapy itself. So we have doctors that we can refer to for help with that. And as oncologists, we also, obviously keep a close eye on our patients, and every time they come in for treatment, we check to see what symptoms have come on as a result of the therapy or the cancer, and try to come up with the best solution to help with those symptoms and support the patient through the treatment and get them through so they can have a good quality of life and they're able to go through their treatment successfully.
Yeah, that's a very important question because, as Dr. Domingo said, we have 2 doctors that do palliative care, 1 nurse practitioner, we have 3 psychologists, and that's a part of the hospice team. Hospice is when you are in the end of the life and there is no more treatment. But palliative care, there is palliative care there, but also palliative care can be at any time. For example, you are a new patient, but you have a lot of bone metastasis, you are in a lot of pain. And you're a witness, so we see you in 20 or 30 minutes and discussing the chemo, the side effects, the plan, questions. We easily, run out of time all the time. So we have a palliative expert that sees you and sits with you. Actually, they are allowed to have very long visits, like 40, 50-minute visits. And they discuss the pain management, for example, They discuss the pain management. They are board certified on that. That's why it's very important. So they focus in pain management. They focus, for example, a lot of patients, when they come, they are underweight, they are malnourished because the cancer consumes them. They focus on that. We have, for example, integrative medicine, or integrative medicine doctor, if he finds indication to give you CBD or THC that you need it, he will prescribe for you. That is very important because it complements a lot what we do. And also, we are the chemo experts, and it's hard for us to keep track of what is the new pill for appetite, what is the new pill for weight loss, what is the new pill for pain management, what are the regulations for pain dispensing medication. So, for example, our doctors in palliative care, they do some sort of contract with the patients so to protect them to go into many other places. And that's why there is a lot of things. That's why we need to have specialists and palliative care, as I said, you don't need to be dying to be in palliative care. You can be from day one, and that's what we're trying to offer the patients as an extra service that can be very valuable for them.
One comment I want to make about symptom management is I think that's the importance of the multidisciplinary approach. Is it's not just having the palliative care doctor, but it's also really the team talking together, really to try to formulate a treatment plan that's going to be best for that individual patient. Much what gets discussed in these tumor board discussions really is what's the functional status of the patient? What is the treatment that they're able to tolerate? So there's always a discussion, and Dr. Block can comment on, what would be maybe the surgical approach that the patient may be able to tolerate if they're not a surgical candidate. What would be the radiation approach that we can use? Is there an alternative treatment to that? What's the molecular profile? Maybe instead of giving chemotherapy, you can give targeted therapy or immunotherapy. And that discussion is really, at the crux of it, is really what is the patient able to tolerate? Because ultimately, the best symptom management is to avoid the toxicity or the symptoms. So there's always a discussion as to what is the patient able to tolerate. In addition to that, we have a pulmonologist. We have the pulmonology team. And sometimes it's really optimizing pulmonary function and pulmonary management. So that is, I think, the importance of the multidisciplinary approach. It's not like we just get together and say, all right, this is the recipe. The patient has this type of cancer, this diagnosis, this is the treatment they're going to get. We kind of have to take all those factors into consideration.
What would be your recommendation to the family? Because we have been talking about the patients. They are the ones who have the pain, the certainty, the fear, but maybe we suffer in silence. the close family. What would be your recommendation as a doctors to the family?
That's a very important question because we, in the last years, we recognize another entity that's the doctors get burned out, the caregivers get burned out much more, you know, and they are not allowed to complain, they are not allowed to talk because the patient is number one, you know. So all of us will sacrifice happily for our loved ones, you know. But maybe it doesn't have to be like that, you know. That's why we are lucky that we have advocate organizations that they go to. The same in our own cancer center, that we really care about the caregivers. And for example, in Memorial, we keep track of what we call social determinants of health. So yeah, the medical side is important, but we want to know if you have food problems, you know, if you have transportation problems. We want to know if you have a loved one to help you or no. And there is a list of social determinants of health that we need to track, because otherwise I can prescribe you the best immunotherapy of the world and you will never show up to the appointment. So we will not achieve our goal. And the same thing with the importance to have the caregivers, but we recognize that the burnout of the caregivers is very important, and this is something that needs to be addressed. You are not Superman, you know, and as I said, we will give our life for our loved one. Probably everybody can say that, but it doesn't have to be like that. You know, like I have a lot of very sad stories because the caregivers get burned out, and you know they have a very difficult times, and the patient also already is in a difficult situation to deal with more. And that is why I think this is a very important topic, that the same as the doctor. I took over in 2001 practice. I was hired, like the Domingo was hired to help me. No, they confuse her with my daughter, but she's not my daughter. I have two boys. She's my partner. And the doctor was 48, and I was like a 32, 33. Well, to make the story short, the doctor died 2 years later. All the patients survived the doctor. The doctor was not supposed to die. And the doctor was burned out, he was extremely depressed. I think he got cancer because of that at 48, and he died. You know? And then we started to talk about many sad stories like that. The caregivers get burned out, the doctors get burned out. And these are things that we need to fix, otherwise we are not going to be successful in this task. You know?
Yeah, and I'll give a shameless plug to GoTo as well. We do care about the caregivers, and we have a couple of different programs where we can connect you with other caregivers, where you can have those one-on-one conversations. There's actually a sign-up sheet in the back. It's called our Phone Buddy program. It's for patients and caregivers alike, where we match you as closely as we can to someone who's walking in your shoes, everything from your age, your demographic, your diagnosis, all of that. So same thing for caregivers. So
they have a very interesting program that they have survivors also. For example, I think 2 or 3 of our patients who work with GoTo, they can give you counseling, either to the family or to the patient. So if you want to talk to a survivor, they connect you with the survivor. And as I said, some of our patients do that happily. And so these are resources that, you know, they can talk to you more about.
I have one last question, and it's been kind of buzzing around here in the back of my mind since we've been talking. And Dr. Gotkin, it's to you, because I think all too often I hear folks who've been diagnosed with lung cancer say they've never seen a pulmonologist, and it just floors me every time, because not only does it seem really logical, I mean, this is a disease in your lungs, you are a lung doctor, like it just makes perfect sense. And I know my mom had her own sort of experience with some pulmonary issues related to COPD. She also had her upper left lobe removed, so the majority of the left side of her lung. And nobody had ever told her, for example, about how she might react in altitude. And not just altitude like I'm going to the mountains this weekend, but altitude I'm getting in an airplane and flying across the country, right? Because I think most folks don't know that they pressurize airplanes at about 8,000 feet. And if you're struggling to breathe at 8,000 feet, you should know that before you get on an airplane and fly across the country. And so things like altitude tests, ongoing pulmonary function tests, can you talk a little bit about?
Yeah, no, I think that we are an important part of the team. I think we should be constant throughout the journey. Like you said, people have other issues other than cancer-related, surgery-related. People have underlying lung disease, and then they go and they have part of their lung removed, and they may be great, but then They may not. They may have some shortness of breath. They may have some cough. They may have some wheeze. Their oxygen level may drop when they walk around. They may need oxygen. They may need inhalers. They may need nebulizers. You know, they're getting radiation. Maybe there's some changes on the CAT scan that look like it's inflammation, but maybe it's pneumonia and they need antibiotics. So I do think it's important to establish with a pulmonologist through your course, because we're here to help. You know, and we do talk with everybody. You know, I speak with Dr. Ayaz if, you know, if there's a new immunotherapy drug and somebody comes in and they're short of breath, and I need to know, do I need to start this person on steroids today because they're having a pneumonitis? Or, you know, with Dr. Block, if someone has some pain because they had surgery, they have a little bit of rib pain, should I start them on gabapentin, or just to help me help the patient? So I do think that it's important for us to be there to answer questions, to help with any potential complications, and to help with the shortness of breath, the cough that may persist during the course of therapy.
Should we be on your team, though?
No, it doesn't. As long as you have a pulmonologist, stick with your pulmonologist. As long as you're happy.
The phone's going to be
I'm not
ringing.
here recruiting patients.
Tomorrow morning.
No, but I do think that a pulmonologist should be a part of your team. Okay?
Okay, thank you very much. Okay.
A huge, huge, huge thank you to our panel. This team and Memorial have been partnered with GoTo for many, many years now. Not only are they a center of excellence, receiving designations for the quality care that they give to their patients here in the community, but Dr. Reyes and others have chaired our 5K. Thank you to those of you who have come out, and thank you to all of you who have actually come here today to be a part of this community event. We love seeing your faces. I would be remiss in not thanking the Beverly Boys. They got here really early today to set up these cameras so you folks at home could watch. Michelle Zay, who's my living room partner in crime, who's somewhere in the back there. The entire GoTo team for their tireless efforts in affecting change in this space. And then, of course, our supporters. I have to put my glasses on for this because the list is long, and without them, we wouldn't be able to bring you this type of programming. So Amgen, AstraZeneca, Bayer, Bristol-Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda. Thank you to all of you for making this possible for our community. Thanks, everybody.
So I'll be brave if you're brave. I'll be brave, but only